Very nice to introduce Dr. Geetha madam. She is the first speaker of this session, lady speaker of this session, and she is a professor HOD anesthesiology from MS Ramaya Medical College and Hospital. She is having a special interest in obstetric, anesthesia, difficult airway, renal transplant, and simulation. Simulation is now the fashion of the day. So she has got achievements, few of achievements which are very important is PG Diploma Hospital and Healthcare Management from IGNOU. Palliative Care course, Indian Association of Palliative Care, and she is a course coordinator, simulation workshop in ISA National Conference at Bangalore and Tamil Nadu, Kerala, Karnataka conferences. It's to her credit, there are 30 presentations in national and international journals. Over to you, madam.
Okay. Thank you, sir, for that kind introduction. I bring greetings from MS Ramaya Medical College, and I also would like to thank the organizers for giving me this opportunity. And I'm very happy to come back to Mysore because this has been my hometown. I did my schooling here. Okay. At the outset, I'm going to be talking about this important topic of optimization and management of brain dead patients for organ donation. And overview, I'll be talking about the organ donation needs, diagnosis of brain death, physiological changes that ensues following brain death, and also about the brain dead donor management. Organ transplant is a definitive surgical treatment for end-stage renal disease, liver disease, or lung failure, or in fact heart failure. But the gap between the supply and demand is widening, and it is increasing. The demand far outlies the supply. Just to give you an overview, in India, around 150,000 renal failure patients are waiting for transplant, and currently we do only about 3,000 transplants per year. And heart is about 50,000, and only about 100 per year is done. And if you look at the brain organ donation rate in India, it's about 0.8 per million. And this has improved quite a lot in the past 5 years. 5 years ago, it was only about 0.05 per million. But this is still dismal when you think of what's happening in the Western country. Spain, it's nearly about 50% of their patients brain dead patients go in for organ donation. And in Croatia and UK as well. This is slightly because there in those countries, it is presumed consent. That means that unless they explicitly mention that they want to opt out of organ donation, they're always considered for organ donation. But whereas in India, it does not happen. It is opt-in. And according to 2017 report, there are more than about nearly 140 deaths secondary to road traffic accident, of which 40 to 50% of them have head injury. And even if 5 to 10% of these are considered for organ donation, we would not be requiring any living donor transplant at all. So you know the magnitude. The reason why it is so lacking in India is because of lack of awareness, maybe because of cultural and social issues, and the concept of brain death is not there at all. Even if it exists, it's only misconception that's there in the public. Hospital also, I'm not talking about the metro cities where the program is ongoing and it's coming up again. It is the suburb or the non-metro cities, the second tier countries where identification and maintaining these brain dead donors is unaware. And so this is the reason why we need extensive program from the government and also probably funding from the program on this important aspect. And it was way back in 1981 that the concept of brain death was explained in Uniform Determination of Death Act, which says irreversible cessation of all functions of entire brain, including brain dead. The person is presumed to be dead, apart from the circulatory and respiratory function. That is the accepted norm before that. But in India, it happened only a decade later. Where brain death was legalized in the Transplantation of Human Act in 1984, where they describe brainstem death as a means at which all functions of the brainstem are permanently or irreversibly ceased. And in this, they describe as to who actually diagnoses brain death. There should be a set of 4 physicians who is appointed or convened by the medical superintendent of that hospital. And out of these 4 people, one has to be a neurophysician or a neurosurgeon. But in 2011, they amended this act because not every center would have a neurologist or a neurophysician. The intensivist in charge of the patient could also act in place of the neurologist. Now, coming to clinical diagnosis. Now, establishing the etiology of the disease is very important. This has to be either trauma or stroke, and not any other cause. Or in fact, sometimes what happens is you have resuscitated ROSC appears, but the patient, it has taken too long, and then you do the other tests to do it. And then you exclude potentially reversible conditions that mimic brain death. Example, intoxication, or the patient is on muscle relaxants or intense hypotension. You've got to rule out this. After you've ruled out these essential factors, you have to demonstrate. And you have a checklist. That is the 3 cardinal signs. First, coma. Coma has to be established, and then the brainstem reflex, and then the apnea test. The coma is absence of response to noxious stimuli, but you may get little spinally mediated reflexes. This is not to be taken as sense of life or a sign of life. And I'm not going into details of the brainstem reflexes. Suffice to say, every textbook has got it. But pupillary reflex, corneal reflex, all the cranial nerves are tested. And then the apnea test. This I thought I'll dwell a little on it. Make sure the patient is not hypothermic and hemodynamically stable. And then you pre-oxygenate for about 10 minutes. And you allow a baseline PSAO2 of about 35 to 40. And then you disconnect from the ventilator. This was old school. But the recent studies have shown that using CPAP improves the use of lungs for organ procurement. So you use CPAP. Apneic oxygenation can be done if you're completely disconnected, and you observe for respiratory effort for about 8 minutes. You're checking if your respiratory center is intact, if PaCO2, and the end point is PaCO2 reaching up to 60 millimeters of mercury, or if this PaCO2 is low beforehand, it should increase at least 20 millimeters from the baseline. And the essential thing, it does not end here. You need to repeat this 6 hours later. We follow the UK guidelines, and it is only after the second testing that you term the patient as brain dead. So what happens after we have? Sometimes what happens is these tests may not be completed or is doubtful. And at times like this, we do the optional testing, which is the EEG. And this, of course, not, even though commonly used, it may not be clinically highly utilitarian. And then there is the cerebral angiography, which is the gold standard. And then the transcranial Doppler test, which is highly sensitive, and the radionucleotide imaging, which shows a hollow skill phenomenon. This is a picture. On the right, you see the normal one, and there you see there is no blood flow at all. And what happens after we've made the diagnosis of brain death? So you should make a formal declaration. This is, you provide the family with the diagnosis of finality. That means the patient is dead essentially, and no decision about stopping is necessary at this stage. And also you allow the patient family to sink into the fact that the patient is dead. You allow a time for decoupling from death to donation. Don't broach the subject of donation at this point of time, because they would eventually be in denial. They will definitely refuse donation. And once it is done, the family or the patient near kith and kin, it should not be patient there, should make the decision to withdraw life support independent of or prior to any discussion regarding organ donation. It is only then that you broach the subject of organ donation. So, and to help us, there are some government aids. In Karnataka, it's the Zonal Coordination Committee of Karnataka, and then the Mohan Foundation in Tamil Nadu and Andhra Pradesh. There's ZCCK and Orbo work, and these people are doing quite a phenomenal work. And ZCCK, in fact, our urologist was a chairperson of ZCCK for 5 years. And so far I've spoken about the indications, but you should also know in whom you should not be taking patients for considering for organ donation. That is HIV. Any systemic viral infection is a no-go, and active malignant disease, and also even if the malignancy of transmission of the malignancy is high, even though it is dormant in or they're called cancer-free, that is in melanoma and choriocarcinoma. However, bacteremia and fungemia is not a absolute contraindication. So now coming to the next, what happens after brain death? There's a pathophysiological changes. There is brain injury or neuronal tissue damage secondary to either trauma or strokes. Stroke can be due to ischemia or intracerebral hemorrhage. This causes neuronal damage, increases the ICP, secondary to brain swelling, or because of the mass effect itself. And this triggers off a vicious cycle of mass effect, leading to cerebral ischemia and then the herniation. The end result of this is that there is liquefaction of brain and there is complete brain necrosis occurring. And for just to kind of reiterate on the human brain, 3 important regions, what we learned in our anatomy. Cerebrum, which controls the memory and the consciousness. That's the coma stage, which we are checking in the brainstem death analysis. And cerebellum, which controls the various muscle functions. And then the brainstem, which has got the important structures. The pathophysiological change, even though the brain is the neurological center is what it starts off. It starts off a cascade of event which involves all the other systems like cardiovascular, pulmonary and metabolic. You must recognize what are these changes occurring. Either prevent the bad changes that's occurring or at least decrease the damage because of these changes that's occurring. So the first intense thing that happens is when there is brain injury, there is elevated ICP. And as a compensatory mechanism, hypertension occurs, and there is catecholamine surge. Hypertension is catecholamine surge is to maintain the MAP because your CPP is your MAP minus ICP. Secondary to this, you get the peripheral vasoconstriction, tachycardia because of this catecholamine surge. And if it goes on, then you'll have the myocardial dysfunction. And in fact, it mimics a systemic inflammatory response syndrome with all the metabolic or the inflammatory mediators like IL-6. Then the hemodynamic changes that occur depends on which area of the brain is involved. And normally it starts from the rostral to caudal area. So the first midbrain pons is involved. So you've got a mixed vagal and sympathetic activation. There is bradycardia and hypertension. That's Cushing's reflex occurs. But if medulla is involved, you'll get the sympathetic activation. That's the catecholamine surge that I was talking about. And later there is vasoplegia when the spinal cord is involved. Coming to the pulmonary changes. Pulmonary changes, what is pathognomonic or the end thing is the pulmonary edema that occurs. It could be neurogenic or cardiogenic, but most commonly it's the non-cardiogenic, which is because of the SIRS syndrome, like picture like that occurs. And another important aspect is the hormonal changes that occur. Secondary to ischemia of the pituitary and the hypothalamus, which lies behind the medulla. There is depletion of vasopressin, cortisol, and thyroid hormones. This will lead to diabetes insipidus, hypothyroidism, and hypocortisolism. And then there is the hypothalamic involvement. There is loss of temperature control. In fact, talking about temperature control, prevention of developing hypothermia is more important than treating it later. Then the metabolic changes that occur is hypernatremia. It is caused by volume depletion and diabetes insipidus. Sometimes you should monitor the sodium. The ideal sodium level to be maintained is less than 155. Above 170 is associated with primary non-function of the grafted liver, and above 160 is associated with PNF of the grafted kidney. And glycemic control also goes haywire, and this is very important to maintain organ viability as well. If it's more than 200, PNF of graft of pancreas increases. And all these changes will not occur in all the patients. However, hypothermia occurs in 100% of all brain dead patients. Hypotension is seen in about 80 to 85%, secondary to vasoplegia and hypovolemia. It should have been hypovolemia. And diabetic insipidus is secondary to hypothalamic and pituitary dysfunction. And there is arrhythmias and pulmonary edema as well. So following this, in case, the normal sequelae, as I was talking about, is the cardiovascular instability and brain death. Then, okay, if you do not treat it, circulatory collapse occurs within 48 to 72 hours. So it's very important to treat these causes to maintain the thing. There's the general care of ICU, which I will not go into detail about, to prevent infection. So here the optimization shifts from cerebral resuscitation to optimize organ function. So this is done usually by the hemodynamic monitoring, both static and dynamic. And just before me, sir spoke about the dynamic and the static indices, so I'll not dwell on these issues. Optimization, normally what is used is the WIPS approach. WIPS approach was initially used to treat the shock, and even here, using the same principles, you can manage or mitigate, optimize these patients, which is ventilation, infusion, pumping, and pharmacologic and specific therapy that we use. And you follow the golden rule, or the goal is the rule of 100, which is to have a systolic pressure of more than 100, urine output of more than 100 ml per hour, and PaO2 and hemoglobin, blood sugar about 100 milligrams per deciliter. These are the broad outlines that you monitor with. So circulatory support, usually hypotension is more common. If there is any ongoing hemorrhage, you've got to treat that. And next is the fluid selection. If there is hypotension, first and foremost, you know there is vasoplegia, so you have to correct fluid. Crystalloids is preferred. And if there is hypernatremia, half normal saline is to be given. Colloids to be avoided, especially hydroxyethyl starch, because it can cause renal epithelium damage. And PRBCs to be considered in case of anemia, but the goal should be around 30 hematocrit value. And in case, if EF is less than 40, or if the patient continues to be hypotensive despite volume resuscitation, then you'll think of doing inotropes. But you keep it use as sparingly as possible. Studies have shown that using inotropes is not very good for post-graft viability in the recipient. However, dopamine and dobutamine, however, yield better result than compared to epinephrine and norepinephrine. But there are some centers which still use norepinephrine. Then there is the hormone replacement therapy. If EF remains less than 40, or in case there is hypotension that continues, they use the triple therapy, which was conventionally used, but it is controversial. We use methylprednisolone, vasopressin, and thyroxine. Vasopressin is usually advocated if there is diabetes insipidus with hypotension, and wherever they've used vasopressin instead of noradrenaline, the graft outcome is much better. And you can use desmopressin, that is about 1 to 4. This is employed only if there is no hypotension and diabetes insipidus has set in. Reason is desmopressin acts on the V2 receptors, which is in the renal tubules. Methylprednisolone is given empirically once brain death diagnosis is made. There are various regimens that use. Conventionally, we give 250 milligrams followed by 100 milligrams per hour till organ retrieval. And the various studies have shown that it has improved the organ outcome, and also it causes the immune modulation as well, because I said brain death is like an SIRS syndrome. Then there is thyroxine. Thyroxine again is shown to be of help. In the West, however, they use IV thyroxine. Since we don't have IV thyroxine here, oral 300 to 400 microgram 8th hourly is suggested instead of T3. And insulin therapy as well, because to maintain a target of 180. Pulmonary support, this suffices to say that you need to have normal oxygenation, normal carbon dioxide level, and what is more important here is to have a lung protective way of ventilation, which is low tidal volume and moderate PEEP. Renal support I've already spoken about, and coming to about the organs available by donor team, you know, one organ can give life to about 8 people if you monitor or optimize these organ system optimally. That is heart, lungs. Lungs previously was taken as a single unit and transplanted at tune. Of late, the lung is taken as an own entity and only one recipient gets it. Kidney, 2 people, and other things that can be taken, tissues as the skin, cornea, and bone and tendons as well. And there, you must be aware of the competing physiological needs, which is for kidney, you want to give more fluid, which is bad for the lungs. So you have to judiciously monitor it. And overview of the donation process that occurs, it is chaotic sometimes, so you need to have proper coordination, cooperation, and communication in the theatre. And whatever has been done in the ICU should be followed in the operation theatre as well till organ retrieval. And muscle relaxation is very, very important to give. Don't think that you will have spinal reflexes taking place and that will come in the way of surgery. And other consideration is rapid fluid replacement, communication with the surgeon, especially during the key steps, apparent prior to aortic cannulation, removal of central vein before the SVC is traversed, and inflation of the lung prior to removal. And usually the organ retrieval order is heart is taken out first, then the lung, liver, pancreas, and the kidney. And these are the organ preservation time, heart having the least, which is 4 to 6 hours, and kidney having the highest, that is about 36 hours. To summarize, in India, brain dead program has to be more formalized. Government has to take more active role, and we as physician, intensivists and as anesthetists can recognize potential brain dead patients and early recognition, because the window period where it is retrievable is only about 48 hours after the brain death occurs. Awareness and acceptability of this entity of brain death. And also remember, one thing that I want to say is care of donor is essentially simultaneous care of the multiple recipients who can be saved. Thank you.
Thank you, Dr. Geetha. It was